All right, so it's the top of the hour. Welcome everyone to the second night of Prevent, Treat, Recover, an interprofessional approach to substance use disorder. My name is Brianna. I am the administrative assistant for the Central Michigan Recovery and Education Network, and I will be the moderator tonight. So in this Zoom session, we have two great sessions. Our first one is from 6 to 7. It's the war on drugs, the historical context to the war on drugs. And we have an excellent presenter for that, and I will introduce her in just a moment. If for some reason you clicked the wrong Zoom link, because we do have 3 sessions at this time, here are the other 2 sessions happening at the same time as this session. So just wanted to show this to you real quick and let you, choose if you want to stay. We have great presenters, so we hope you stick around. So without further ado, I will be presenting our first presenter. So we have Dr. Susan DeViste Miller, did it. So she presented last night. If you're new here, she's an associate professor and pharmacist. She practices ambulatory care through Ferris State University at Cherry Health Services in Grand Rapids. She's worked in mental health and specialized in foster care for several years, pursued substance use disorder education, and attained her final degree of PharmD from FSU. She serves on the Kent County Opioid Task Force, Kent County Refugee Health Work Group, Ferris State University Rural Opioid Prevention Network, and so much more. So welcome, Susan. We are happy to have you. I will stop sharing my screen so you can go ahead and get started.
Wonderful, thank you. I am going to share my screen. I knew I'd have some technology snafus. There we go. We'll start from the beginning. Well, good evening, and thank you to everyone for coming this evening. This is a topic that I have very mixed emotions about. The topic is war on drugs, the historical context to the war on drugs. I have mixed feelings because when I talk about it this evening, I'm going to try my hardest to not bring in a lot of bias, but I can tell you that I have a lot of bias on this topic. I do not have any financial conflicts of interest. I am an advocate for harm reduction. I serve on the Grand Rapids Red Project Board. And so I do bring in some of the aspects of harm reduction. I am not an advocate for drugs, but I am an advocate for people. And I want you to know that I am not an expert in legislation or the laws or the history of this. This is through a lot of research that I have done. I read a lot. And so some of the books that I have read in the past couple of years have really brought me to this topic. If you are interested in this topic, I have a few books that I don't get any financial support from this, but some really great books. One is Chasing the Scream by Johann Hari, which is an excellent book. I'm going to read a quote from this book in a moment. It's The United States of Opioids, A Prescription for Liberating a Nation in Pain by Harry Nelson. And so if you're interested in this book, this is where I actually got a lot of my ideas for this presentation. I want to read just for a moment about this. These are the 3 objectives that we're supposed to cover. We're going to recall legislative action, identify key components, and then discuss the impact of the war on drugs on people itself. And the reason why I wanted to talk about this is a quote from The United States of Opioids by Harry Nelson. By the late 19th century, addiction was an acknowledged problem in America. The U.S. had as many as 200,000 people with opium addictions by then, a disproportionate share being women, based on prescribing patterns for menstrual pain and hysteria, among other things. This was also the beginning of the shift from the use of opium to more purified derivatives, such as morphine and heroin, which were all injectable through a hypodermic syringe. Opium, in all of its forms, including heroin, was a central part of American medicine. Available with no formal regulatory oversight structure. So this was in the late 1800s or the late 19th century. And so think about that in the time that we are now. And so like 150 years, the process that we have gone. The big thing that we're going to talk about is the war on drugs, which occurred in 1971. So I'm going to ask for you guys to input. Why do you think the United States declared a war on drugs in 1971? Right. I think there's some chat here.
Vietnam protesters, Richard Nixon.
Yes. Yeah, so it's really interesting that there are a couple people or a couple groups of people that were marginalized, including the Vietnam protesters, and it occurred with Richard Nixon. And so we're going to go through that here in the next short amount of time to really go through that. So there we go. So the timeline that I'm going to start with is 1890. In 1890, you could order cocaine from Sears and Roebuck. For those people who don't know what Sears and Roebuck is, it's an older version of Sears, but they had a catalog, which is a paper. It's a big old thick paper that had, you could buy anything in it, including cocaine for $1.50. If we were to purchase that now, according to inflation, it'd be $43 that we could order cocaine through Sears. Cocaine was not illegal and could be ordered. Some states began to regulate the drugs in the 1800s, but this wasn't still in the 1890s that you could order it. In 1909, the Smoking Opium Exclusion Act was enacted. It banned the possession, importation, and use of opium for smoking. However, opium could still be used as a medication. This was the first federal law to ban the non-medical use of a substance, although many states and counties had banned alcohol sales previously. So as long as it was prescribed as a medication in 1909, you could still get it. If there's any pharmacy students on here, which I did see some come in, then you know about the Harrison Act of 1914. This regulated and taxed production, importation, and distribution of opiates and cocaine. Prescribers stopped prescribing and they became illicit substances. Then in 1919, we had the 18th Amendment, which prohibited the manufacturing, transportation, and sale of alcohol in the United States. So we have a time frame of 5 years where alcohol could still be purchased in most states. This was the National Prohibition Act regarding the alcohol. In 1933, so we're talking 14 years later, we had the 21st Amendment, which overturned the 18th Amendment, and we could purchase alcohol again. In 1937, the Marijuana Tax Act was passed. This is a federal law that placed a tax on the sale of cannabis, hemp, and marijuana. This act was introduced by a Republican from North Carolina, a representative from North Carolina. It was drafted by Harry Anslinger. Harry Anslinger is a very important person in our history. While the law didn't criminalize the possession or use of marijuana, it included hefty penalties if taxes weren't paid, including a fine of up to $2,000 and 5 years in prison. Harry Anslinger was the first commissioner of the Federal Bureau of Narcotics. If you were like me and curious and you Google Harry Anslinger, you're going to find a lot of interesting information on him. I'm not going to spoil it because it will put in some of my biases towards this person. In 1951, we had the Boggs Act. It was a mandatory prison sentence. So if somebody was found guilty of a felony or upon conviction that they were having marijuana or cocaine or opiates, that they would be fined no more than $1,000, in prison for no more than 1 year, or both. In 1952, this was amended to be the Narcotics, Drug Import and Export Act and set mandatory sentences for all drug convictions. A first offense conviction for marijuana possession carried a minimum sentence of 2 to 5 years and a fine of up to $20,000. So we're talking 1952 and $20,000. $20,000 is a lot of money today, but in 1952, it was even more. In 1956, there was the Narcotic Control Act, where drug offenses included the death penalty for selling THC, which is marijuana, to youth. In 1969, drugs were determined to be a serious national threat. They had seen an increase in crime by juveniles and street crime in the 1960 to 67 timeframe. There was a call for action at the state and national level. So we have this time where it's a national threat. In 1970, as Jerry did tell us, that former President Nixon had a decision to make about this. Nixon signed the Controlled Substances Act into law. It was a statute that called for the regulation of certain drugs and substances. If you are in healthcare, you know about the 5 controlled substances. So controlled ones are illegal substances. They're highly addictive and have no medical use. Then you go through 2, 3, 4, and 5, where 5 has the least amount of addiction. The Schedule 1s were considered to be the most dangerous. They posed the highest risk for addiction with little benefits. This included marijuana, LSD, heroin, ecstasy, and a slew of others. The rise in the recreational drug use in the 60s was likely the reason that Nixon focused on targeting some types of substances. As part of the War on Drugs initiative, he also increased federal funding for drug control agencies, which proposed strict measures such as the mandatory prison sentences for drugs. He also announced the creation of a special action office, and it was headed by Dr. Jerome Jaffe. I don't know as much about him, but if you know anything about Anslinger or have been interested, hopefully you're finding some really interesting facts about him at this time. So in 1971, drugs on war was declared after the Controlled Substances Act went into play. It was public enemy number 1. In 1973, the DEA was established. So this is the Drug Enforcement Administration, and it was to fight drug use and smuggling. Interestingly enough, that when this was established, there were 1,470 agents and a budget less than $75 million. 2017, there were more than 5,000 agents and their budget was over $2 billion. Some really interesting information as well is that in the mid-70s, the war on drugs didn't really have a lot happening. In fact, there was states that decriminalized marijuana possession. And then former President Jimmy Carter's political campaign, he ran on the idea of decriminalizing marijuana. We know that didn't actually occur. In the 1980s, we had former President Ronald Reagan, who continued to work with the efforts of the war on drugs. We know that Nancy Reagan, who was our first lady, had the Just Say No campaign. This is where some of my bias is going to come in. It is a campaign that really stigmatized those that had drug use. There are studies out there that show that there's stigma even before people start using, to the point where they feel such guilt and shame about even using that they won't seek help. They won't go out and get healthcare met. They won't talk with people about it because of the shame and stigma. We were told from such a young age, don't do drugs, they're bad for you. This is your brain on drugs, and it would show a fried egg. And so it really led to a lot of shame and stigma. Unfortunately, it also led to severe penalties for drug-related crimes, mass incarceration for nonviolent crimes. What I find really interesting is that President Nixon, one of his it was someone that worked for him, it was his domestic policy chief, John Ehrlichman, and I apologize, Mr. Ehrlichman, if I pronounce this incorrectly, but in an interview with Harper Magazine in 1994, he stated that he explained that the Nixon campaign had two enemies, the anti-war left and Black people. So those that were protesting the Vietnam War, and as well as Black people. He goes on to state, we knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Didn't we know we were lying about the drugs? Of course we did. And this was in 1994. Last I checked is 2021, and we still have a lot of these same policies in place. So let's continue with this legislative timeline. In 1986, we had the Anti-Drug Abuse Act. This act allowed for $1.7 billion to fight the war on drugs. Again, more mandatory minimum prison sentencing. It was heavily criticized as having racist ramifications because it allocated longer prison sentences for offenses. So this is really interesting. For the same amount of crack cocaine, which is often used by Black Americans, so if you use the crack cocaine, you would get a longer prison sentence than if you used a powdered cocaine, which happened to be used more often by white Americans. And so it's really interesting the amounts that you could have of each of them to get the sentences. There was also concerns with this same act that persons of color were targeted and arrested on suspicion at higher rates than their Caucasian counterparts. We know that the rapid incarcerations went from 50,000 in 1980 to over 400,000 in 1997. It's just really interesting how we skyrocketed the number of incarcerations for this. In 1989, George W. Bush appointed the first drug czar under the Office of National Drug Control Policy. This is William Bennett, whose goal was to make drug abuse socially unacceptable. Now remember, alcohol is socially acceptable. In 1995, the Sentencing Commission acknowledged racial disparities in their sentencing. They made recommendations to Congress, but no changes were even made. 2003, there was the Illicit Drug Anti-Proliferation Act. It targeted ecstasy, methamphetamine, and predatory drugs. In 2004, the U.S. Embassy Kabul Counter-Narcotics Implementation Plan. Its goal was to reduce heroin production in Afghanistan. Interesting enough, we've had a lot of wars in Afghanistan, and it is the world's leader in opium production. So think about some of that how that correlates to some of our wars and drug use. In 2010, Congress passed the Fair Sentencing Act, which reduced the discrepancy between crack and cocaine offenses. So finally, many years later, we do have that remedied a bit. Since 2009, we've had the legalization of marijuana, and we've even had some decriminalization of illicit drugs. Oregon passed a measure in this past election year, so fall of 2020, where they actually legalized illicit drugs for personal use. And when I want you to remember, for personal use. So it's a huge shift. What it really does is says that you can have possession of it, a certain amount, including heroin, cocaine, methamphetamine, oxycodone, and this all went into effect February 1 of this year. But it was that those persons that had these illicit substances in their possession could be fined $100 and it was a citation. However, if you agree to a health assessment, then that citation could be dropped. And so it's really interesting that the Oregon Health Authority is the one who is working with this. Marijuana has also been modified in a lot of states. We have Michigan and Colorado, which were some of the first ones, but we have Arizona, New Jersey, Montana, and South Dakota that also legalized marijuana for adult use. Interestingly enough, that while it is legal in some states and in some cities within those states, the DEA still considers this to be a Schedule 1 and an illegal substance. They can make the choice to arrest somebody on those charges. All right, we have all of this legislative action that's happened over the past 130 years. What has that done to our incarceration rates? So if we look at from 1925 to 1985, you can see that we went from around 100,000 federal and state prisoners to almost just over 481,000. So we know that it was a huge increase. Let's look at this when we're looking at some of those acts. So in 1914, we didn't have a lot of federal prisoner population. We see prohibition from the 1920s to 30s, and we see an increase in that federal prisoner population. We have the war on drugs in the 1970s, and we slowly start seeing this increase in prisoner population. Then we start adding in that sentencing reform where there are offenses, there are minimum sentences for these offenses, and they're felonies. So we're seeing this drastic increase of federal prison population. All right. Now I'm going to try really hard to show this YouTube. I'm not great at it with technology, but I really want to give someone else's perspective on this. So that means I have to do a little bit of movement here. Okay, I think I have to go into my how I share my videos. Or is it my mute? Okay, I think, so Brianna, can you tell me if you hear this in just a moment? Can you hear this?
Yep.
Thank you.
Can't see it though.
Okay, you can't see it?
You'll have to do a reshare of your screen to that video.
Now, can you see it?
Yes, I can.
Okay, let's hope we can hear it too. Let's start over. Can you hear it?
Nope.
Okay. Let's see. Let's go back to my. Let's see. There is a chat statement, but I'm not sure what it is.
Yep, someone said turn on closed captions maybe. If you want, you can put the link in the chat and I can go ahead and try to do it.
Okay, let me do that. Oops. Of course, everything now that I touch, I am messing up. Thankfully, I don't get too upset about things like that. Because this happens quite a bit when it comes to me and technology. And I can continue to speak until you can get that to play. Or do you want to try and get it to go up right now?
I will share my screen.
All right. Thank you.
Can you hear it?
Yes, thank you.
In 1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing Everyone wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the US blew up. Today, we imprison more people than any other country in the world. China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine, even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the US prison population disproportionately, locking away Black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis, but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above-ground marijuana industry. A few states south in Louisiana, they're still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to Black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above-ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but former felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in Black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared the so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
Thank you. So I think it's really good for us to see a perspective of persons that are outside of us. But so that was in the United States of America. But let's look at a country such as Portugal that in 2001 decriminalized the possession of drugs for personal use. And again, this is personal use such as Oregon has done. If we look in 1999 at Portugal, their overdose deaths were pretty high compared to what they were in 2016. If we look at their new HIV cases due to injecting compared to 2017, and look at the number of persons incarcerated. So they have a very similar process where if you are found with drugs on your person, then you can get a citation or you can go through a process to receive the health treatment should you want that. So it's very interesting that in another country that they had 81% of all of those penalties or persons that were caught, that 81% of them had those sentences suspended because they actually went into the treatment versus 19% who had the penalty. You can see that over time that the drug use has decreased. That's what the, when we look at the second on the bottom right, that they've eliminated a lot of the punishments for personal drug use. The drug uses haven't skyrocketed as many people had predicted. You can see that it has decreased. And then the rates of continued drug use in Portugal. Over time, it has decreased. And when we look at the rates of deaths, of drug-induced deaths from 2001 to 2012 in Portugal, again, drastically decreased. And the number of AIDS patients. So we see from Portugal that this has really worked. Granted, there are some downfalls. In every process, there is downfalls. Let's look at the United States now. We have every 25 seconds, someone in the United States is arrested for a drug possession. We have reached 1.3 million arrests in 2015, which is 6 times the number of arrests for drugs. That is more than 6 times the number of arrests for drug sales. We have 1/5 of the incarcerated population, or over 450,000 individuals serving time for a drug charge. We also have more than 1 million people on probation and parole for drug-related offenses. Incarceration is negligible on patient safety. Crime rates have trended downward since 1990, and researchers have attributed that this is due to other factors besides the mass incarceration. As you heard Jay-Z in his YouTube video there, that Black Americans are 4 times more likely to be arrested than their white counterparts. We know that Black Americans make up nearly 30% of all drug arrests, even though they're only about 12% of all substance users. Black Americans are nearly 6 times more likely to be incarcerated for drug-related offenses, despite equal substance use rates. And almost 80% of the people serving in a federal offense are Black or Latino. We also know that the war on drugs has cost a lot of money, nearly $1 trillion since 1971. In 2015, the federal government estimated $9.2 million every day to incarcerate people with charges on drug-related offenses. That's more than 3.3 billion annually. I could go on and on. There's so much money put on mass incarceration for persons who have drug offenses, for possession. So there's some information on the marijuana legalization that would save about $7 billion per year in averted enforcement costs. And we can actually yield billions of dollars in tax revenue. Now, I am not an advocate for drug use. I'm not even an advocate for anybody buying or to have this. But what I'm saying is that we can redirect our dollars should we really take a look at the war on drugs. And then when we talked about this last night, there is the crisis. We've had the 3 waves. We're now in the 4th wave with the gray matter. We know that more than 750,000 people have died from this. We also know that in 2017, President Trump declared a public health emergency because of the opioid overdoses. I also presented last evening in my keynote where we talked about persons who are getting drugs from a drug dealer are at the highest risk for overdoses. If we could legalize some of this, would we have drug dealers if we could get the consistency? I'm not fighting for drug use or for even legalization of drugs, but what I am saying is that we need to look at, are we past time?
Nope, you're about 5 minutes until we should start questions.
Okay, thank you. And so I want us to think about that there's the misconception of weakness or choice when it really comes to persons having substance use disorder, the diagnosis of it, even just using it. So really looking at the stigma that goes along with the war on drugs and the use of it. We talked last night that there are so many negative impacts that this war on drug has resulted in: discrimination, disempowering, marginalizing, excluding, making it so patients are unwilling to seek help. There's shame. People go through withdrawals in the criminal system. There's self-harm and blame, as well as an exacerbation of overdoses. We know that there are tons of people, it's over 67,000 a couple years ago, 67,000 people who died of overdoses. We saw that COVID has impacted where this rate has actually increased to more than 81,000 people who have died from overdoses. We have this 5-point strategy to combat the opioid crisis, and yet we have seen that the war on drugs has really done a lot of this pain, and we're not looking at that. We need to change policy. We need to look at legislation. We need to look at healthcare coverage, allow medication for addiction treatment in the jails and the prisons, having acceptance of medication for addiction treatment. And quite honestly, we need to have public awareness and attending sessions of this to even just get the conversation started. Because if we could get the conversation started, then we can have more discussions, which is exactly what I want to do right now, is have more of an open discussion with you who are attending this evening to get your thoughts. So thoughts, conversation, I guess even questions.
So if you had any questions or comments, you're welcome to either take yourself off mute or chat them in. Thank you so much, Susan. That was an amazing presentation, and I'll leave it to you guys to have a discussion.
Andrew, do you have a comment or some discussion points?
I had one thing, it was more of a comment actually. I think that one of the things that would help with kind of the opioid crisis and kind of recreational use of opioids would be a better alternative for pain. I mean, if they used to use heroin as an antitussive to stop coughs and things of those nature. So when we develop new antitussitives with less risky side effects and a larger therapeutic index, they were able to stop using heroin and or essentially for one of its side effects or one of its reactions that it caused, but new options for pain to kind of limit the use of opioids would kind of take a lot of them off the market.
Yeah, absolutely. I think it was either last Friday or Monday of this week, there were 2 studies that were discussed about oral naltrexone for pain. And so really, is that a possibility? I think it's a really good opportunity. Having alternatives so we're not treating persons with some of these substances. Other thoughts, comments, questions? Sydney.
Yeah, I have a question. Thank you again, Dr. Miller, on your presentation, both today and yesterday. Very informative and very interesting. Just myself being an undergrad pre-pharmacy student at Ferris, I automatically thought about what myself and my peers could do. We're highly motivated individuals, as I'm sure you know, being a professor for the College of Pharmacy at Ferris. So do you have any thoughts on anything like us students could do to help reduce the stigma?
Yeah, it's honestly things such as this, having conversations with people, making things normal, meaning having conversations about substance use, having conversations about the uncomfortable, such as I spoke about last night, really talking and normalizing the difficult parts of it. So I have a lot of students that come to my clinic and they will say, I don't know how to talk about mental health related problems. I don't know how to talk about substance use. How do you do that? Get comfortable, shadow people, have conversations. If you have people that work in social work or nursing or actually in anything, have conversations and make it comfortable so that you are willing to talk to every single person about it, and not in a confrontational way. But so I'm going to be honest. I have never done an illicit substance, but I know how to snort and I know how to inhale because I ask questions and I'm open to learning because I want to help my patients who do use these substances. Like I talked about last night about the glass pipe to snort. If you don't get clean ones and you are sharing your glass pipe that you're snorting with, or you're using your glass pipe for inhaling, you're going to share possibly Hep C, HIV, having those weird conversations. A lot of times I tell the students, don't tell my grandparents or even my parents, but I know how to take a pen apart and use it to snort. Not because I do it, but because I need to know for my patients. Having those conversations, finding out about harm reduction, finding out about things we don't know about and that really are not comfortable.
Yeah, I love that.
And we do have a question in the chat. Would something like a MAP program in a prison decrease violence in the US prison system? Why can these withdrawal symptoms not be controlled and treated in the prison systems, or why is it not?
Ryan, that is a great question. So I don't know if it will decrease violence or not, because honestly, that's not something I've looked at. But what I can tell you is that if it were to be utilized in the prison system, we would not have as many people going through withdrawals. Withdrawals from opioids is horrible. It's like the worst flu you can have. People report it's such a miserable feeling. The reason why it's not used, it's a stigmatized treatment. People, I can tell you, I have a family member who is a paramedic and a firefighter, not in the community that I live in, but he literally said to me a month ago, if I didn't have to give naloxone to so much, I could do such a better job in the community. I said, what? He's like, well, you know, those addicts, they keep using it and I have to keep going back to the same houses. And I said, do you ever go back to the same home of a person who has diabetes and has used sugar? Do you still treat them with insulin? So, and he was like, what? But those are the stigmas that are out there. So having it in prisons and in criminal settings such as jails, in juvenile detention centers, it's still stigmatized. There are a couple large facilities in the state of Michigan that are working towards the medication for opioid use, but only for persons who had started it prior to being incarcerated. So if you're on it, you could continue it. Very few people are actually willing to start the process of the medication for addiction treatment.
And just to chime in here, Ryan, if that's something that you're interested in, I definitely suggest looking up and researching the prison systems in other countries, because a lot of other countries, it's more of a rehabilitation back into society where they do the MAP programs and things like that to help rehabilitate and introduce back into society. Whereas our prison system, not so much, but that's for a different topic.
But Brianna, that's exactly what this is. You know, that's what I wanted us to get out of it, is that there are other systems that are not so stigmatizing or penalizing. My daughter, 16 years old, says to me, Mom, why is our prison system like this when the Europeans, you get a space and you get training and it's not a mark on you for the rest of your life? I'm like, if my 16-year-old can understand this, how come we can't get our adults to understand this?
Mm-hmm. Yeah, so I just had kind of a comment. I'm sure a ton of my peers and I all grew up in the era when DARE was a program in elementary school, and we were systematically taught drugs are bad, and the people who use them are bad is kind of the underlying thing that comes next after that statement. And so it's a weird reprogramming of generations who grew up with that messaging. So it's like, I guess that's kind of my comment, but how do you reach people who grew up with that's the only exposure they've had?
That's my generation, and it has been hard. So I sit on harm reduction boards, and there's some evenings where we have a mission moment, and so they educate us on something. And literally, we took a pen apart and learned how to utilize it. And I just sat there going, holy cow. Or some of my dearest friends now are persons who have been using, who have utilized naloxone because they're worthy. And it's really the discussions, the exposures, the challenging your mindset. I am a just say no child, and I feel it every day. The books challenge me. So I have about 25 books sitting next to my bed to read. Chasing the Scream, I've read this a couple times. United States of Opioids. These are some great books that really challenge you to think about, why do you think the way that you do? I have conversations with so many of my friends from high school who are like, what do you mean it's okay to legalize drugs? And we have conversations, and I really try to keep all of my biases out of it and say, let's look at the facts. But it's hard. Even myself, I've come home at night and going, I have to process this. Like, I can't say anything because if I say anything when I'm at the Red Project, I'm going to just like, my colleagues are going to say, what are you doing? Like, don't you understand how we're supposed to be more open? And so stepping out is really hard, but just take one step and do some reading, do some investigation, look at Harry Anslinger. I challenge everyone to look him up.
And talk to people. There are plenty of us here who have had experiences in substance use disorder and opioid use disorder. It affects everyone. But we probably have time for only one more question. So if someone has a dying question they would like to ask, I ask that you do it now. If not, we'll move on.
Yeah, this is Jerry. I'm wondering when we're going to start looking at addiction as the cure and not the problem, and start looking at the real problem. I mean, until we start looking at the sociological, physiological, psychological, behavioral problems that are causing addiction, making drugs legal is no different than in the 90s saying Oxycontin took care of pain, because it did. It relieved pain, but at what expense? So let's be careful when you're saying, you know, MAT is the gold standard, as they say. Yes, it saves lives, but if you're not doing the treatment for the physiological, psychological, sociological, behavioral problems, you're not curing anything.
Right. You're right, Jerry. You know, last night when I spoke about the prevention and addressing personal and family issues and the ACEs, the adverse childhood experiences, and really making sure that we're addressing so much more. This is not an easy world to live in, and addressing abuse and misuse of people themselves, and how this leads to as I stated, a quote from Jess Tilley, trauma was my gateway drug. There's so many reasons why people use substances, and really making sure that we're addressing them. You are so right.
Perfect. Well, thank you. Thank you for that last question. It's a perfect one to end on. So at this time, this is when you would switch sessions. You have 15 minutes to go grab some food, drinks, use the restroom, things like that. So if you would like to stay on for the Reversing the Stigma, Understanding the Importance of Naloxone, I ask that you join a little bit closer to 7. I'm going to put those who wish to stay on for that session into the waiting room while we get ready for you. And then the other session is Addiction is a Family Disease, and the Zoom link is there below. Additionally, if you are not able to attend the 7 to 8 session, please go ahead and fill out our exit survey. We really appreciate all responses. This is a chance for us to learn and grow and try to do this again sometime. So thank you so much, Susan. We really appreciate you, and your presentation was absolutely amazing. So for those who wish to go to the next session, either stay on and I can put you in the waiting room, or log on to the other Zoom session now. Thanks, everyone.